So you have 5 minutes and all your slides to impress the audience, who will then vote. So this is Dr. Topen Austin, who's from Cambridge University Hospital's NHS Foundation Trust, who will tell you about his Shared Learning Award application. Topen.
Well, thank you very much, and thank you to NICE for giving me the opportunity to tell you about some of the work carried out by the East of England Neonatal Neuroprotection Team. Hypoxic ischemic encephalopathy, or HIE, is a devastating condition. Caused by a lack of blood flow and oxygen to the brain around the time of birth, around 20% of infants will die, and a significant number of survivors will go on to have lifelong neurodisability, including epilepsy, blindness, and cerebral palsy. This places an enormous physical, psychological, and financial burden on the individual, their families, and the wider society. Indeed, the lifetime cost of looking after a severely disabled child runs into millions of pounds. And until recently, the only real treatment for this condition has been supportive care. After over 20 years of research, from basic laboratory science through to large multi-centre randomised controlled trials, much of it done here in the UK, it's been shown that cooling an infant by just a few degrees shortly after birth can prevent this brain injury in a significant number of infants. In 2010, the National Institute of Health and Clinical Excellence published their guidelines on therapeutic hypothermia, suggesting it should be the standard of care. And as any new treatment moves from research into clinical practice, it's the responsibility of us as healthcare professionals to ensure that all eligible patients receive the same high quality, safe and timely care. Given the fact that these babies are born unexpectedly in any delivery setting, and that cooling should be started as soon as possible after birth, presents us with a unique challenge. So with support from the Health Foundation's Closing the Gap scheme, we undertook a specific project to improve the quality of care for infants suffering from HIE by developing a coordinated regional service for neuroprotection, follow-up and family-centred care in the East of England. This quality improvement initiative was ambitious and wide-ranging. Key aspects were engaging both local units as well as families, trying to understand the issues that faced them in the days and weeks after the birth of a baby with HIE. A major programme of education and training was delivered to ensure that the crucial early management of these infants met the standards outlined in the NICE guideline. A key learning point early on was to ensure that we obtained reliable, measurable data so that we could demonstrate whether changes actually reflected an improvement in the service. One of the standards was the importance of core temperature monitoring, and before the guidelines were published, only none of the 15 hospitals in the region were monitoring core temperature. Working with all the units, we now have 100% compliance in this standard. Also reflecting improved early management, this graph shows that in the 8 months to March 2012, all infants in the region were cooled to the target temperature of 33.5 degrees within the crucial 6 hours after birth. I'd like to tell you Ella's story. She was born by emergency caesarean section when doctors noticed her heart rate fall suddenly. She was born pale and floppy and did not make any spontaneous breathing effort. The local neonatal team resuscitated her, and it was clear soon afterwards that she was suffering from HIE. They turned off her incubator and nursed her in an open cot to start the cooling process. The specialist neonatal transport team arrived, placed her in a cooling mattress, and kept her temperature stable for the journey to the regional intensive care unit. There, critically ill, she was cooled for a further 72 hours. You can see the water-filled cooling wrap around her body and head. 5 days after she was born, Ella had her first cuddle, a mother her moment Rachel described as amazing. And pictured here at 9 months, Ella is clearly a happy, thriving little girl. When talking to families, the consistent message has always been that of feeling alone and isolated. Despite having a similar incidence to Down syndrome, HIE has very few support groups and public awareness is low. This photograph was taken at one of our coffee mornings we now organise for families so they can meet other parents and discuss and share experiences. The biggest lesson we learnt from this work has been to listen. Listen to the local healthcare workers about the challenges they face in the early management of these infants. Listen to the families and learn from their experiences and their stories. Cooling represents one of the most significant steps forward in the management of sick newborn infants in recent years. The NICE guidelines ensure that this treatment becomes the standard of care. But the real impact has been to use these guidelines as a starting point to engage health professionals and families into improving the whole patient journey and hopefully improving the lives of these vulnerable infants. So I'd like to thank everybody in the east of England and beyond for working so hard to make this project such a success, and I'd like to thank you for your attention.
Thanks, Topen. Don't vote yet. They'll all be fantastic. But wow, what a presentation that was. We have time for one question. Anyone would like to ask a question? It's not compulsory. Anyone got a... Seem to have covered all the bases there. And you've got off without a question, so well done, Topen. Excellent presentation. Next up, I'd like to invite Dr. Chris Daly from Manchester Mental Health and Social Care Trust. Big round of applause for Chris.
Thank you very much, and thank you to NICE for inviting us onto this presentation. I'm sorry, my voice is very hoarse. Unfortunately, I was at Albert Square on Monday night cheering home the champions of the Premier League for the first time in 44 years. So apologies, I hope my voice holds out. I'm here on behalf of a whole team of people who are involved in trying to implement some of the alcohol strategy for Manchester involving the suite of NICE guidance. We're referring to these three particular suites of NICE guidance which came over the last 4 years. First one being the public health guidance, looking at brief interventions and screening predominantly. The second guidance relating predominantly to inpatient care and the physical disorders associated with alcohol. And then the final piece of guidance, the one looking at the specialist services interventions in terms of pathways and treatments for those identified with alcohol use disorders. So we took on a very big approach within the trust. Ours is a mental health trust, and we were aware that there were a number of issues relating to the way that our patients were using alcohol. Unfortunately, Manchester comes top of the league in other things as well, such as alcohol-related harm. So we realized this was a big area, and we also recognized that there was a variation in the way that NICE guidance was being developed and, in each of these areas. So we had a number of support services that were in a variety of organizations. We were seeing wide variations in practice across the trust, and these included disparities in the number of patients receiving screening for alcohol, the management of harmful drinking, the provision of brief interventions, very effective interventions in the early stage of drinking problems, variations in the way that detoxifications were applied, and also the signposting for the available ongoing support. And there were also a number of serious incidents that were being recorded, which seemed to highlight that these gaps in knowledge and this disparity in service was having a very negative outcome for patients. And also there was an understanding that was a negative attitude to some of the staff groups around alcohol within our patients. So one of the things we thought was that we could use the NICE guidance to promote and drive forward positive change so that there'd be better outcomes. The way this was, we had a Trust NICE implementation group that supported, first of all, a gap analysis to see where the gaps were within our services, and then, through the quality assurance framework, try and drive forward positive change. The work plan that we developed included a review of all the required treatment guidance so that we were NICE compliant in terms of that. We had a very successful Trust Effectiveness Day focusing on NICE alcohol guidance to promote that amongst all the staff. One of the fortuitous things that happened is that, as well as the changes in relation to the NICE guidance, we were also integrating the community services around alcohol within our trust, and also public health development services were also integrating into our trust. So it seemed to marry up very nicely with the three pieces of NICE guidance. We developed a range of comprehensive and flexible training to meet the needs of our patients wherever they presented within our service, based on the evidence within NICE. And there was also the purchase of required equipment and materials. This included, for instance, on inpatient units having breathalyzers, proper protocols around the use of Papronex vitamin supplementation, and the screening tools and the brief intervention tools that could be used for this group of patients. There was also a particular work focused on cultural change. We had a day on malignant alienation. It sounds very interesting, but actually it was a way of looking at some of these attitudes and staff beliefs. We also had a flexible and tailored training program, both for the inpatient staff based on the NICE guidance applying to inpatients and the community staff. And we developed some tailored pathways for alcohol services through public health through to secondary care. We were also monitoring the impact of this through the prescribing, through the Datix incident reporting system, and it was being monitored closely by the pharmacists who led a lot of the work in this area. And Emma and Petra are here from the pharmacy department today. There's also a use of screening and assessment and brief intervention tools on all the wards, and breathalyzers were also being used routinely on the wards as well. This was part of the implementation work. And as you can see, what we tried to do was go through all the tiers of services, right from Tier 1 with the public health input, right through to Tier 4, the more specialist inpatient detoxification and rehabilitation, to make sure that those pathways were clearly identified. So what do we feel has happened so far? We feel that the pathways are certainly clear now, and the staff tell us that they understand those pathways, and therefore they feel better supported in their work. There's been an improvement in the delivery of evidence-based interventions for inpatients, in the use of safe detoxification and appropriate vitamin regimes, and those are being adhered to now, which is very positive. We've got improved access to effective brief interventions and advice, and also the clear pathway into the support after patients leave the inpatient units and from the community mental health teams into the community alcohol teams. We've also had a very useful input from public health right down at ward level. So the development officer has been working on a one-to-one basis with some staff around delivering these effective interventions. So why were we successful? Why do we feel this has been a useful way of developing things? I think NICE guidance came out at a very opportune time for us in Manchester. We were developing a Manchester alcohol strategy, and those involved were very keen that the NICE standards were at the core of what we did there. The transfer of community services and public health occurring at the same time really seemed to marry up those three pieces of NICE guidance. I suppose, as always, it's about having the right sort of people who are enthusiastic, and they've had to battle, but I really think they're starting to win the battle now. We're currently collecting data to show these improvements, and particularly around screening, identification, and the management of harmful drinking. And we've also, with our commissioners, agreed sequin targets around screening, and hopefully in the future, brief interventions as well within our target population. Thank you very much.
So clearly Chris wasn't to stay to take a question. I've got a question. Do you think if we'd sort of decommissioned professional football in Manchester, that would reduce the alcohol problems?
I'm sure there'd be some other problems associated with that. Well, I must say, being a Manchester City fan, there was a few moments there when we thought we were going to be drinking an awful lot.
Were you sitting in Albert Square saying to people, be safe and sustainable in your drinking, as you were?
I was too busy screaming, actually.
Okay, excellent. That's probably the correct answer. Okay, finally, Dr. Bobby Mann from West Middlesex University Hospital. Big round of applause for Dr. Mann, please.
Thank you very much. Thank you for the invitation to come and talk to you today. My name is Bobby Mann. I'm a respiratory physician at West Middlesex Hospital in Isleworth. And I'm going to talk to you today about the COPD discharge care bundle. COPD, or chronic obstructive pulmonary disease, is a condition characterized by lung tissue damage and airway narrowing, and is predominantly caused through smoking. It causes 30,000 deaths per year in England and Wales and is the fourth leading cause of death worldwide. In a national audit in 2008, carried out by the British Thoracic Society and the Royal College of Physicians, it was shown that in the 3 months after discharge from hospital with an exacerbation of COPD, that 14% of patients died and nearly a third were readmitted, so there's significant morbidity and mortality associated with this condition. In our own locality, there are no community services for COPD, so there is no pulmonary rehabilitation and there are no community oxygen monitoring services. And this explains why our hospital had one of the highest number of COPD admissions per 100 patients on a COPD register in London. In order to tackle this problem, we implemented a COPD discharge care bundle on the respiratory ward in 2010. This was supported by Clark Collaboration for Leadership in Applied Health Research and Care, and the overall aim was to improve patient care and reduce readmission rates, as well as reduce variation in care and increase compliance with national guidelines. The discharge bundle is essentially a checklist of 4 evidence-based recommendations known to improve outcomes for patients admitted with COPD. So essentially all current smokers were offered smoking cessation advice. All patients were taught inhaler technique. Everyone was given a COPD information booklet with a section on self-management, and all patients were given an outpatient appointment for 4 weeks before they left hospital. In addition, for those patients that consented, a phone call was made 3 days after discharge to check on their clinical progress, although this bit was not evidence-based. So using improvement methodology, a multidisciplinary team was set up. This consisted of doctors, nurses, a patient representative, physiotherapists, and the smoking cessation team. This team carried out a process mapping exercise and mapped the patient's journey from admission to discharge. Regular teaching sessions were held, as well as workshops on smoking cessation and inhaler technique training. Data on compliance was entered onto a bespoke web tool, and any issues of non-compliance were addressed using a plan, do, study, act cycle. Regular MDT meetings were held, and readmission rates were analysed by the hospital's information and performance team as part of the local SEQUIN requirements by local commissioners. So how did we do? This graph shows the compliance with the bundle at 21 months. The blue bars show the result of a pre-bundle audit of 50 patients admitted to the hospital under various teams across the hospital and shows the level of care. The yellow bars show significant improvement in level of care after introduction of the bundle. The yellow bar on the far right shows the overall compliance with all 4 elements of the bundle, and this currently stands at 93%, thus showing that the project is sustainable. The 28-day COPD readmission rate before the bundle was 25%. Our commissioners wanted this reduced by 10%. In the 1 year after introduction of the bundle, the readmission rate had by 26% to 18.4%. This is a cost saving of £31,500 by preventing readmissions, and the Trust also saved £30,000 by hitting their SEQUIN target. 2 years on from the start of the bundle, the readmission rate remains 18%, with the readmission rate in our hospital being 22 to 24% in recent years. In terms of patient experience, 85% of patients said they found the bundle useful or very useful. And from a staff experience questionnaire, 78% thought the bundle was useful in improving patient care, improving their knowledge and making their work easier. 71% found it easy or very easy to complete. So in conclusion, the care bundle approach can improve patient and staff experience and may help to reduce COPD readmission rates. Key lessons learned in terms of implementing and sustaining a service improvement project, in having regular MDT meetings to keep everyone engaged and enthused, record and analyze data regularly so you can see how the project is going and address any issues of non-compliance. Regular education and training sessions are important, both as an ongoing reminder of the project to healthcare staff, but also to take into account turnover of staff. It's important to communicate results and successes to the team. And finally, raising awareness of the project is important, not just with other medical teams and hospital managers, but also with local commissioners and GPs. Thank you very much for your attention.
Thanks, Bobby. Anyone got a burning question they'd like to ask Bobby on his presentation? It was always just wonderful, wasn't it, the way you completed the audit cycle? Fantastic. Thank you, Bobby. Would you like to take a seat? I don't know whether we have a slide with the 3 choices on, but we're basically going to vote. And then Mike Rawlings is going to come on and the certificates will be given and the winner will be announced. So fairly simple. If you think the first presentation, Integrated Coordinated and Family-Centred Neonatal Neuroprotection Service across the east of England, is the winner, you press 1. The Alcohol Service 2 and the COPD Service 3. You have 15 seconds to vote, I guess, when the timing comes up. Get your keypads out. Everyone got their keypad out? Anyone lost their keypad? Anyone can't find their keypad? Okay, time to vote is now when the thing comes up. You have 30 seconds to vote. So you can keep changing your mind if you like. It's the one you press as the time runs out is the one that we will record. Very exciting, isn't it? Almost as exciting as Britain's Got Talent. 3 excellent evidence-based presentations of getting nice guidance into practice. As well as developing services, in future will come up and people will say this is how the services were commissioned entirely on the basis of the new quality standards. We'll have quality standards awards, won't we, in a year or so? And the results are... Come on. Very exciting. Simon's sweating. Amanda's gobsmacked. The winner is... Cambridge University Hospitals NHS Foundation Trust. Congratulations to Topen. Please welcome to the stage, in what could probably be his final year as chair of NICE. Here he is, Mike Rawlins. Hi, Mike. Do you want to give us some brief thoughts on what you've heard?
Yes. Actually, I thought they were all superb demonstrations, and thank you very much, all three of you. But there's got to be a winner, and so Dr. Austin, come along, and on behalf of your team, there is a fantastically valuable, you'll get thousands on eBay for it, and the certificate. So thank you very much indeed. Thank you, well done.
Oh, there's photographs, Mark. I think we need to do photographs. Do you want them here? Come on then, come on up. So you go that side.
And you go that side.
I'll go that side. Love the camera. Tits and teeth. Tits and teeth. Excellent. Well done. Well done. Very good. And do we get photos with the winners as well? Do you want runners-up photos too? Would you like a runners-up photo? Be very good for the corporate, whatever it is for your hospital, wouldn't it? Yes. Runners-up photos too? And there are certificates they get as well. So we'll do photos one at a time. Hand the certificates over for a round of applause. Very good. Okay, and let's all together. You go in the middle. We're on the outside. The roses between the thorns, so you have to go in the middle. Lovely. Straight down the camera. Lovely. Well done. Excellent. Congratulations. Well done. Well done. Well done. Well done, City.